Desktop. All right. We are recording. So, uh, today we'll go through fluid and electrolytes, and then cell injury alteration kind of covers inflammation as well. Um, Pretty sure that's how I have it set up. Let me just peek at my. Let me just make sure. Yeah. So we'll talk about that as well. We'll cover that for next week as well.
Okay.
So, all right. Before we start, let's go over test. As far as the tests go, they are online. We use Respondus. We have not next week, but the following week will be the exam. 50 questions, multiple choice. Everything from your Word documents that are posted on Blackboard. That's where the exam will come from. We are going to be using Respondus, so there should be a link on Blackboard. If not, let me know. It should still be active. That links you to, I believe, the library, and that's where you download Respondus through. Test it beforehand, so make sure you don't have light behind you because that blinds the camera. That affects it. Light should be in front of you or above you. When you do the exam, pick up your computer, show me a 360 of everything. Show me your desk. No phone should be on your desk. I will allow you to use a sheet of paper, but you must hold it up at the beginning of the exam and at the end of the exam. Show me both sides. Okay. Um, Quiet environment. Don't have TV going on in the background, music, none of that. Okay. So sit somewhere quiet. I had a student that would sit in her closet so her kids wouldn't bother her. It just has to be a quiet place. I'm going to give you the entire week to access the exam. You will have 1 hour and 30 minutes to complete the exam. Once you start, timer continues. So make sure you have that time to sit down and complete it. I will email you guys a password to access the exam. Okay, so it's not accessible till that window and using the password. All right. And
Hmm?
let's roll. Where is. There we go. Come on, click. There we go. So, when we talk about fluids in the body, this has value depending on certain medications that are administered to patients. They may distribute into the water in the body. So, the amount of total body water can affect how much medication you must give. Now, depending on where you are in life, it alters it, and it's really due to like muscle mass, distribution of tissue, um, how much fat you have, since water doesn't absorb into the fat really. So it depends on that. Um, Dehydration, overhydration, any of those can have an effect on it. When you talk about the two groups that are most affected by diarrhea, it's young children and elderly. Because of the children can't rehydrate properly, and the elderly because of the low volume of total body water. So they're the most susceptible to dehydration from diarrhea or excessive vomiting. So hyperemesis can be very difficult for them. Okay. All right. So in AMP2, you guys learn the compartments. The problem is we really only teach you these two compartments right here. Intracellular fluid, extracellular fluid. In reality, every compartment has that. So we have in the blood, we have intracellular, extracellular. In the lymphatics, if there's cells in there, there would be intracellular, extracellular of lymphatics. Inside the tissue itself, there is intracellular, extracellular um, compartments. So the rule of thumb is the fluid always follows the solute. So if I say in the bloodstream, I inject someone into their blood with excessive solute. What will happen is, if I give them a 15% or we'll say 5% saline, because normal saline is 0.9%, zero point 0.8, somewhere in there. Let's say I give them 5% saline into their bloodstream. Well, water is going to leave this intracellular compartment. Water is going to leave this extracellular compartment. The intracellular water in there will leave into the extracellular compartment here and then out into here. Whoops. And then same thing with the interstitium in the tissue. It'll leave the cells into the extracellular interstitial fluid and then into the extracellular fluid in the bloodstream. It's going to follow the solute. Same thing, vice versa. If I give them a hypotonic solution, I give them a 0% IV, which would kill them, okay? The water is going to flood all the tissue. It's going to flood into the intracellular here, into the extracellular here, and intracellular. Same thing here. And cells will swell, cells will lyse. You will destroy tissue. So you really only see that with typically patients that have like psychosis. They're the ones that are going to overconsume water. Someone gives the wrong IV solution. So that's why it's important. We check multiple checks. Typically with IV solutions, the tech in the clean room makes it, they check it, the pharmacist checks it, and then the nurse checks it before administering it. They scan it, they check it. All right. So three confirmations. So there's no boo-boo, right? Do boo-boos still happen? Yeah. Every once in a while, something slips. People get complacent in their job and they're just clicking. That's where you get into trouble.
What
Um,
would a reason for different IV
Solutions.
concentrations be? Yeah.
It depends on, the status of the patient. Like if we need to deliver a drug, but they are hydrated, we don't want to overhydrate them. Like if they have congestive heart failure, we don't want to overhydrate them. So we may deliver it in something that has a higher salinity. That way we can actually help pull water out of them. Or we may deliver it with, they have like dextrose, mannitol. Mannitol is used as like a diuretic, for example. So they could use something like that. It just depends on the patient's status, is really what it's going to come down to. And that's what alters what they deliver it with. And then also certain drugs, like certain drugs must be delivered like with albumin in them.
Hmm.
They bind to the albumin. So we may alter what the fluid is according to that as well.
Okay.
So that's in pharmacology. That's where you really will cover that, especially in nursing. If you're going into that route, that's where you will go into detail with that. All right. So, when we talk about hypotonic, cells swell, cells lyse. So, when you look at neurons, that's really what happens. They demyelinate. So, in those patients with like psychosis and they overconsume water, or someone that consumes distilled water, it's very hard to do naturally. But you hear about wonky cases. Like a few years ago, there was a case here in Georgia where the people were compete. It was a radio show, and they had a competition where the people had to drink, I think, a gallon of water, keep their hand on the car. If they let go to go urinate, they lose. And so the last person standing wins. Well, the lady somehow held her urine, it backed up into her system, and her neurons demyelinated and she died. Um, so that's kind of wild. You do see it also in alcoholics. When you go to rehydrate alcoholics, you have to hang typically what's called a banana bag, which has um, all these minerals and vitamins in it, because they're so altered from the overconsumption of alcohol over an extended period of time that their cells will demyelinate too. And I believe it specifically has to do with a thiamine deficiency in them. So they usually just hang a banana bag to be safe. Isotonic, that's our normal status. That's 0.9% outside, 0.9% inside. That's what we want to be at. Hypertonic, there is more solute outside than there is inside. There is less water in this situation, so the cells crenate or shrink or shrivel. You can recover from this. There isn't cell damage per se. Can it cause damage way downstream? Yeah, but that would be the extreme scenario. You are at a hypertonic status in your bloodstream, in your body, if you feel thirsty. The hypothalamus is sampling the osmolarity of your blood constantly. When that osmolarity increases, it means you're in a hypertonic point. It stimulates the thirst center, telling you to drink water. So it's kind of wild when you think about that as you go through your day, how often you feel thirsty. So if you see me, I've got some source of water on me. Especially because like teaching, like throat gets dry, stuff like that. So I'm always carrying water. So you guys learned about this in AMP2 as well. Hydrostatic, osmotic pressures or oncotic. So I learned oncotic. I always teach oncotic. Oncotic is albumin. Albumin is really the biggest force that pulls towards it. So in our textbook, for some reason in AMP, they rely on osmotic, which is movement of water, but they focus more on sodium causing this movement of water. But in reality, albumin is the bigger player. So in this point, once again, there is hydrostatic and oncotic pressure in every compartment. So you'll see in the interstitium between the tissue and the blood vessels, there is oncotic or osmotic pressure. There is hydrostatic pressure pushing out. The same thing in the cells, hydrostatic pressure, osmotic pressure. It is in every compartment. So when we talk about, if someone has liver failure, well, they don't produce albumin. Because they don't produce albumin, this pressure starts to push into every compartment. The water moves into every compartment. So you see, like, I think we talked about it, it's ascites where they develop this fluid inside their abdomen, excessive fluid. So maintaining these pressures is important. Maintaining albumin levels are important. So here we have questions for y'all. So if the blood osmotic pressure is 25 millimeters of mercury and the hydrostatic pressure in the capillary is 30 millimeters of mercury, what would be the net filtration?
Shouldn't it just be five?
So what you have to tell me what that is, where is the 5?
Okay.
Where is it going?
Um, into the capillary because
Correct.
it has the extra pull.
Correct. Wait, no, sorry, not correct. Into the interstitium. My apologies. I'm like writing as I'm listening. No, it would be into the interstitium, right? Hydrostatic pressure, they're saying capillary hydrostatic pressure is this pressure pushing out. Osmotic pressure, they're saying the albumin in here is pulling back in at 25. So our net change is 5 millimeters of mercury into the interstitium. We are creating positive pressure into the interstitium. Okay. Now here's where we alter things. The next question. What would be the net filtration pressure above if you also figured in that interstitial osmotic pressure was 3 millimeters of mercury? So they're saying over here, there is a pull into the interstitium of 3 millimeters of mercury. So now what is it?
So it would just be two. Mm, the But it should be in the same direction, shouldn't it? Because it still the difference is on the one side.
So if we're putting 5 with the previous 2 into the interstitium, and now we're saying we're pulling 3 also into the interstitium.
Okay.
What is?
So
Uh-huh.
yeah, it'd still be the two left over.
We're saying 30 is pushing into interstitium,
Hmm.
25 coming back into the blood. So I have 5 out here now. We're saying the albumin or proteins out in this tissue is pulling another 3 on top of that.
Oh, so it'd be eight.
Correct. So now we have 8 pulling into there. Um, there's also the interstitial hydrostatic pressure that can be pushing back. If you've ever seen patients, women that are wearing this like compression sleeve on their arm walking around, they've had a radical mastectomy because they've removed the lymphatics in the axillary here. There's now this doesn't drain. So that hydrostatic pressure increases. The interstitial hydrostatic pressure, sorry, decreases. My bad. Decreases. And so what happens is there's no opposing force to the blood or capillary hydrostatic pressure. And so they get edema. So they wear that to create compression to create a interstitial hydrostatic pressure to push it back into the veins and drain their arm. So you may have seen that at some point. So edema is exactly that. Uh, what's happening is there is excess fluid that is collecting in the interstitium. There are lots of causations. So lymphedema, that is what I was talking about. That's where you get protein structures in there and the lymph is not draining it, and so we get what's called pitting edema. Okay, and then non-pitting edema, that is like fluid overload. So congestive heart failure, for example. So the pitting is what they do is they pinch, like they took their hand and just pinch down on it, and it pits and it stays for a little bit until the fluid migrates back in. And here they're showing obstructed lymphatics. I think that's obstructed veins, actually. Yeah, that should be obstructed veins. So they put a like a radioactive isotope in here, so we can image it, and they
Hmm.
can see like there's lack of flow in here. You can see like there's just little pieces, and that's it, and it's dark. So there's obstruction of the vein there. So that would be like in a DVT situation. Generally now, deep vein thrombosis, and so that's another causation of like of edema. Generally now they just ultrasound it. Ultrasound can pick it up and see it. There's no need to do this whole process. Patients swallowing this, waiting for it to migrate. It's too long. Okay.
And that stuff tastes nasty.
Yes, it does. I had to take it once for a head arm MRI because I was having cluster headaches back in the day. So fun. All right, what does ADH do for us?
It pulls the water back into the system.
Pulls the water back into the system. So it anti-diuretic hormone. It's not going to allow the aquaporins to be placed. And so in the kidneys, we will pull water back into bloodstream. Once again, when you feel thirsty, ADH is being released. What inhibits ADH?
Um, oh gosh, it's an R word, I think.
There's two
I
things:
can't remember.
caffeine and alcohol. And
Hmm.
that's why after you consume either, you have to urinate and it's very clear. You're losing a lot of free water. What's wild is when you look at like caffeine, the half-life for caffeine is, I believe, 5 hours, 4 hours, somewhere in there. 4 or 5 hours. Let's say 4 hours. So let's say you drink a 16-ounce coffee. Let's do a venti. You went to Starbucks and you got a venti coffee. So 20 ounces of coffee at 8 a.m. At noon, you still have 10 ounces. 4 hours later, you have 10 ounces of caffeine in your system. At 4 p.m., you now have 5 ounces of caffeine in your system. At 8 p.m., you have 2.5 ounces. So the effect of caffeine on the body drags on. So that's one of the reasons you shouldn't be drinking caffeine in the afternoon, because it's going to affect your ability to sleep as well. So your ability to rest. So we get into this nasty cycle of I'm not sleeping, so I'm tired, so I drink coffee. I'm not sleeping, I drink coffee, right? Endless games.
So what about all those people that like they literally never drink water and I've only ever seen them drink soda?
I don't know how they do it. My wife and I always talk about that. Like I remember like in high school. I never used to drink water. Now I'm like dying if I don't have water every like 30 seconds. But then again, I didn't drink coffee then. I did have soda. I don't know. Maybe my body weight has changed. They're lean, so their total body water is, better versus me. There's many reasons. They ignore their thirst. My father-in-law is like that. He drinks caffeine all day long. I never see the man drink water. I'm like, how are you functioning?
Yeah, one of my siblings drinks soda all day, and the other one drinks coffee all day. No water.
I mean, there is water in it, right? They're primarily water. It just has caffeine and other stuff in it. At some point, your body's gonna be like, I'm not letting go of the water. It's gonna try and fight it in other ways. So in other ways is gonna be like producing aldosterone so that we can have more sodium in the blood and pull the water in. Um, their body's gonna shift and try and hold on to the water as much as possible. They're pretty salty people.
I was wondering if the sugar content involved in that kind of cycle
Well,
really
it
plays
can,
any.
especially when you talk about like diabetics. Like if their A1C is higher, that sugar it creates osmolarity. It's going to pull water, and that's the whole destruction when you talk about diabetes. That's what's happening. The sugar's inside the cell, water follows, cell swells, cell gets damaged. That's the whole pathology there. So, but yeah, I don't know how they do it. All right, ADH is produced by the
Kidneys or liver. It's one of those two things.
hypothalamus.
Oh, yeah. All right. I'm not good with
You gotta
remembering things.
refresh. You gotta refresh on the AP2. Okay, when blood osmolarity is
Low.
high,
High.
high. The salinity, think about it in that sense. If I lose water, I'm holding more salt. The salt to water ratio, right? Say we
Hmm.
started here. As I lost water, the salt level is high, water level is low. So osmolarity is high, water is low. So the concentration of solute is high. So it senses that, releases it. If a person made too much ADH, so we'll talk about this. This is SIADH syndrome of inappropriate ADH. So they produce a lot of ADH. The osmotic pressure of the blood would, so you have this situation now. They're not getting rid of water. Would osmotic pressure increase or decrease?
Shouldn't it decrease since they have more like water hanging around?
Correct. The like albumin to water ratio is off now. The albumin is real low compared to water, or all solute is real low compared to water. So this is that overhydration situation. So in these patients, they tell them there's two options depending on the one they have. If it's central, that means they don't produce ADH. We can give them a drug called like vasopressin or desmopressin, and that can help regulate them. If it's nephrogenic, it means they don't have the receptor on the kidney. They just have to monitor water intake. If they drink too much, it could cause harm. So they do that. When the level of ADH is increased in the blood, the osmotic pressure of the urine. So this is a fun one. So osmolarity of the blood is high. So we release ADH. ADH means we're going to pull water out of the urine filtrate and pull it back into our bloodstream. So in the urine now, osmolarity is increasing. I have tons of solute and I don't have much water. So osmotic pressure of the urine should be increasing. So be mindful with these kind of questions what compartment they're going to be asking in. Is it in the bloodstream or is it in the urine? All right. If a tumor were to produce abnormally high levels of ADH, blood pressure would be
High.
high. High is correct. And there are tumors of the pituitary that can have an effect on this. Tumor of the hypothalamus could have an effect on this. And then we talk about paraneoplastic tumors, which are tumors in the lungs, and they secrete these random hormones that are similar to other hormones, and you see these situations. So sodium balance, hypernatremia, hyponatremia, that's we're just talking about there's too much sodium, too little sodium. So we're saying hypertonic, hypotonic due to sodium. So like if we have too much aldosterone, we hold on to too much sodium, they can enter hypernatremia. ANP is going to get rid of sodium, so they can go into hyponatremia. Angiotensin 2, hypernatremia, but due to the increase in aldosterone as well. So the hormones controlling, we just ran through those. So make sure you refresh on those. Okay. This is an interesting case. This is this renal artery stenosis. By doing this, you activate the renin-angiotensin system. And so they go through the whole cascade, making aldosterone, making angiotensin 2, 1, all of that. And so they hold on to more sodium, onto more volume. So typically, this one you see in, they do a correlation with, I think it's like younger females, if I remember correctly, typically in their like 20s. They come in with like raging hypertension for no reason. Um, and when they image it using, once again, like a radioactive isotope, and they image it, they can see that stenosis. And so what they do, they go in and through a vessel, they go in and they put a stent in. So the stent is like a tube. They balloon it open, issue disappears overnight.
Why women in their 20s?
It's just a higher correlation there. So as we go through this course, you'll see like when they do like studies on these diseases, they'll see certain populations for some reason have more of it. And so that's just that situation. It doesn't mean it can't happen outside of that population. It's just that is the most predominantly place where we see it. So for some reason, when it's forming embryologically, there is a pinch. So kind of wild. Um, so if sodium increases, so hypernatremia, what happens to plasma volume? You have more salt in you. What happens?
I mean, it should go up because you're going to retain more water.
Correct. You're going to pull more water in. So what's going to happen to blood pressure?
Same thing.
Go up. Yep. And then what would happen to atrial stretch?
That would also go up.
Correct. And so what hormone are we going to release?
Is it the angiotensin? That's
ANP. ANP is going to be released.
ANP.
Atrial natriuretic peptide hormone. We also have BNP in the brain. That also would be released. They both have the same effect. They cause sodium loss in the kidneys. So for question 6, is aldosterone produced as a result of hypernatremia? It should be no, it should be the other way around. Aldosterone is causing hypernatremia. Same with renin. It is a causation of hypernatremia. All right, sodium imbalances. So if we have hyperaldosteronism, we're going to hold on to more salt. So is that hyper or hyponatremia?
If we're holding on to more salt, then it's hyper.
Correct. Diabetes insipidus is
Losing all of our water.
losing all of our water. Are we going to lose electrolytes with that?
Yes.
Correct. So would sodium go up or down?
It'll go down.
Correct. So is that hyper or hyponatremia?
Hypo.
Correct. Diarrhea, same thing. You're losing large volume of water and you lose electrolytes with it. You lose bicarb, all of that. So this would also cause a hyponatremia. Inappropriate ADH secretion, hyper or hypo?
Hyper.
So if I secrete ADH, what do I hold on to?
Salt. Water.
Water.
Yeah.
So sodium, water. Water goes up. Is my salt concentration as high?
No, it's lower.
So it'd be hyponatremia.
Hypo.
Dehydration. Let's say I'm losing water and I'm not rehydrating. I'm losing water, so sodium is up.
Sodium goes up. Yeah. So
So
it's hyper.
correct. 5% dextrose water infusion. So my wife runs into this issue at times because nurses will come to her and be like, "Oh, let's do this and let's hydrate with this." And you can't do that necessarily because of the status of the patient. So if you're at 0.9% sodium and I give you pure water with dextrose in it, and they see that 5%, they go, well, it's fine. It's going to add sodium. They'll be fine. They'll be, hypernatremia. They'll be hyperosmolar. It's not the same. You have to match each electrolyte. So by doing so, we're adding water. We're not adding sodium. You get a hyponatremia. So you got to be careful with these different IV solutions. Oops. Potassium balance. So here, same thing. Hyperkalemia, high potassium, hypokalemia. Um, and it's a inverse relationship when you talk about in the kidneys. As hydrogen comes back into the kidneys, potassium goes out, and vice versa. If we're peeing out hydrogen ion, then potassium comes back into the uh, oh, I think they're doing collecting tubules here. So here, hydrogen is going out in the urine, potassium is coming back into bloodstream. There's our hyperkalemia, acidosis situations. And then in our, here, they're getting rid of potassium, they're pulling back in hydrogen ion, and we get this hypokalemia. Okay. All right. So in patients, when they come in DKA, diabetic ketoacidosis, in that situation, potassium levels are high. They're in a hyperkalemia because of this shift, because of this acidosis situation. And so when we don't correct the hyperkalemia. We don't touch it because we know it belongs in there. What we do is administer insulin. When you administer insulin, it drives the potassium back into the cells and it corrects it. Um, and even then, they will, depending on how long they've been in DKA, I guess they'll give them potassium as well because in the urine system they've been getting rid of that excess potassium and it's now like in the bladder they can't pull it back into their bloodstream and into their cells, so they will administer potassium on top of that. um, Hypokalemia delays repolarization, so when you talk about in the heart that the potassium needing to rush out of the cells to cause repolarization. There's less potassium in the cells at this point, and so the cells can will not repolarize as quickly. They'll stay in the plateau longer. So you get arrhythmias potentially with this. Diarrhea, I've got listed in here. Diarrhea causes hypokalemia. You lose potassium that way. So in severe diarrhea situations, like how we said in children and in elderly, you start to see hypokalemia in them from water loss. All right. So if there is hyperkalemia, will the blood become more acidic or basic?
Um, okay, so it should, is it acidic or am
Acidic.
I wrong?
Acidic. Because you're going to pee out the potassium and pull in the hydrogen because of that co-transport or antiporter system. So you're going to pull back into your bloodstream the hydrogen ion as you lose that potassium, try and get rid of it. All right. Will aldosterone be made?
Yes.
Yes. Okay. Will produce more aldosterone to try and dilute that solute, the potassium. That's really the reason for it. It's also to get rid of the potassium. It helps get rid of the potassium, the sodium potassium pump. That's the other reason. All right. Um, so alterations in potassium, kind of covered this or mentioned this, is going to affect repolarization. So when you look at this point, so P, Q, R, S, T wave, okay? Between the S and T, we're starting repolarization of the ventricles, relaxation and repolarization of the ventricles. As calcium is altered, you start to see the T wave being shifted, and you can even see inversion of T waves. Inversion of T waves, this is indicative of either ischemia, so they're having chest pain, or so that's your angina, or a heart attack in the past. So this is non-STEMI. Non-STEMI is non-ST elevated MI. STEMI is ST elevated MI. So here with this big old T wave, that could be indicative of STEMI. So depending on the patient, they usually, look at an older EKG if one is there, but otherwise they go off symptoms and identify it that way, along with certain enzymes in the blood. So they test for troponin 1, which is indicative of recent MI. It's damage to muscle. There's also CKMB. That's an older one. They don't use it too much because if someone gets like in a car accident and they like, have a crush injury, CKMB goes through the roof. So it's not 100% indicative of MI. Okay. So insulin drives potassium into the cell. So would they be hyper or hypokalemia?
Um, into the cell, so there'd be hypo
Correct. Laxative abuse, they're losing potassium in the stool. Hyper or hypo?
hypo.
Hypo. Kidney failure. I'll let you think that one through on your own.
I mean, if their kidneys aren't functioning at all, shouldn't they be hyperkalemic because they're not releasing any of it?
Correct. They can't pee it out, so it all builds up inside of them. ACE inhibitors. So ACE inhibitors stop angiotensin 1. So you stop holding on to aldosterone or stop making aldosterone. So you don't hold on to sodium. You get rid of sodium. And who's antiporter with him? Potassium. So would your
So,
potassium increase or decrease?
should decrease. Which,
Increase.
which way? Sorry, increase.
Increase because you're peeing out the sodium. In order to pee out the sodium, I have to pull in the potassium. Burns, when there's damage to the tissue, they go into hypokalemia. Potentially, they're losing it. And then hyperaldosteronism, we should see a decrease because we're pulling in sodium, potassium is leaving. Calcium balance, so here we're seeing low calcium. So when they have calcitonin, it tones down the blood calcium level. How does it do it? We drive it back into the bone or we urinate it out. And then versus PTH, parathyroid hormone, will drive up calcium in the bloodstream. So it'll eat into the bone in order to drive it up in the bloodstream. Acid base disorders. This is a fun one. And you guys should remember this equation right here on the top from AP2. This is the bicarb buffer system. So this system is incredibly strong. It works all throughout the body, so we can regulate hydrogen ions. So really, in AP2, we only really cover the lung side of it. And we talk about, converting this equation so we can get rid of carbon dioxide and we also breathe out hydrogen ion. Well, also in the kidney, we have to release hydrogen ion in the kidney as a protection, as well as just a way to get rid of hydrogen ion. Uh, we use it as protection against bacteria, so it helps kill bacteria. Okay. All right. This crazy chart isn't in your notes, but you really should memorize this chart. It will make a big difference for you in the future in understanding acidosis and alkalosis and which one is the causation. So, how you read this chart, you always start with arterial pH. If it's less than 7.35, you're looking at an acidosis. Above 7.45, alkalosis. Between the two, normal. Okay? So we look at acidosis. The next thing you look at is their bicarb and their carbon dioxide. If the bicarb is below 24, it's a metabolic acidosis. Then we continue on and we look at carbon dioxide again. If it's less than 40, they're trying to breathe out the hydrogen ion. And by doing so, there is respiratory compensation. So they have something wrong with their kidneys. They're losing bicarb, they're not reabsorbing it. And the respiratory system, they're breathing faster usually, and they're trying to breathe out that hydrogen ion. DKA, diabetic ketoacidosis. You'll see it in that situation. It's a metabolic acidosis, and they come in and they're breathing very rapid. Kosmol's sign, very rapid breathing, trying to blow off that hydrogen ion. Okay, so each column works the same way. Work through it, learn it. Trust me, it's golden. We won't use that. We'll look at this. So you may want to. Do you have a picture of the chart?
Yeah, I just took one. Let me
Okay.
open it back up.
Okay. So have it up so we can work through these together. So pH of 7.31, acidosis or alkalosis?
Acidosis.
Acidosis. Now we look at bicarb. Is it below 24?
Yes.
And then we look at, so they have metabolic acidosis, and then we look at PCO2. Is it less than 40? Yes.
Uh, yes. Sorry. I was like, where am I looking on the screen?
So it's less than 40.
Yes.
So they have a respiratory compensation on top of that. So would you look at like patients that have like respiratory issues and they get into these situations and they can't get rid of the hydrogen ion, the metabolic acidosis becomes extreme. Okay. So situations like that where they have a failure of both systems, it's hard with those patients. All right, pH of 7.49,
Alkalosis.
alkalosis. So what's now? Where does this fall?
Um, metabolic alkalosis.
Correct. Okay. And then PCO2, is it greater than 20 or 40?
No. So respiratory compensation on this one too.
Correct. What the way that this question was written though is a little funky because if you look at pH and then you look at PCO2, well, it's less than 20. This is a respiratory alkalosis. Then you look at there's no renal compensation. This question wasn't written correctly, so in case you guys look at it that way, don't freak out about it. If a question comes on the test, it'll be clear as day like this. Okay. All right. What do we got?
So acidosis
Mm-hmm.
with so um it's significantly lower than 24. So metabolic acidosis, and then 22 is way less than 40, so also respiratory comp.
Correct.
Uh, yeah.
Correct.
And then
Mm-hmm.
alkalosis, metabolic alkalosis, and respiratory compensation on the other one.
Are we sure?
Okay. So if it's
Respiratory, or sorry, alkalosis is correct.
okay, the So it's 15. That's lower than 24. So that should be metabolic alkalosis.
Was that sign on there saying less than 24 or greater than 24?
Oh, I'm being an idiot. Yeah. All right. Cool.
This is why
Yeah.
we practice. Okay. So,
All right. So it'd be respiratory alkalosis.
correct.
Okay.
Is there,
Um,
continue.
and then let's see. So it'd be renal compensation.
Correct. My puppy is the devil. She grabbed off our wreaths. We have them in the closet, stored in the closet here, and she grabbed a thing off the wreath and chewed it up like a pine cone. Thank you. Appreciate it. All right. Anion gap. So here what happens, there's an equation that you should have it in your notes, which is sodium minus brackets bicarb plus chloride. So when we have anion gap, there is this acidosis that is created. We need to correct the anions, and it's normal anion gap should be 12 plus or minus 2. That's usually the range that is used. And these are common causations of anion gap. And so it's a great memory tool. It's mud piles. So methanol, you find methanol in moonshine. This is why like moonshine's outlawed. Because when they're making moonshine, the first 20% and last 20% are usually methanol when you're making alcohol. And so it's supposed to be poured off when you're making it. But like these guys want to make money, so they don't get rid of any of it. So there's usually methanol in there. Um, Methanol is also found in windshield washer fluid, the winter fluid, because it stops it from freezing. So you'll find it in that situation too.
So are
Uremia.
alcoholics out there like drinking window fluid?
Yep.
Oh, crazy.
My wife had a really neat one recently. Piper, hold on, let me close this door. She keeps on going in and grab more of them. My wife had a really interesting case not too long ago. Patient was found unconscious, down, and she had vanilla extract bottles next to her. She drank vanilla extract, and there's methanol in it. So,
All right. I didn't know that there was methanol in vanilla. I
yeah.
was like, I knew it was alcohol soaked.
Yeah. But when you cook it, it comes out, so it's not a problem. It's not an issue then. You burn it off. But she was consuming it. That was a new one for me. I've never heard that one.
Yeah.
Um,
Vanilla isn't cheap either. So like,
yeah.
I feel like alcohol, you can get cheap alcohol.
She probably lifted it from a store or something. That would be
Mm,
what I would think. Too easy to steal something like that, especially because the bottles are like flat. You can tuck it wherever. Kind of
hmm
thing. So it wouldn't surprise me. Okay. Um, Uremia, so that's just buildup. The kidneys aren't functioning very well. DKA, we talked about that. In diabetics. Um, I don't even know what paraaldehyde is or phenophorum. They're probably some variation of like formaldehydes. That would be my assumption there. Iron, too much iron can cause this lactic acidosis. You see this when people exercise extreme and they consume alcohol. The lactic acid from fermentation builds up in their tissue. And so, because the enzyme that breaks it or reverses it back prefers to break down alcohol. And so they get a buildup of the tissue. Ethylene glycol, you find that in antifreeze. That's where they're getting that from. And then salicylates, that's your aspirin. So aspirin overdoses. So there are some equations for you to go through here. Same thing. So what you'll do is you look at don't they're in acidosis, right? And then
hmm
we look at sodium. So we have 130, and then in the brackets we have bicarb 20 plus chloride 101. So I've got an answer of 121. We subtract that from the sodium, and so we get an answer of 9. So 12 plus or minus 2, they are in an anion gap situation. Negative, positive, negative, negative anion gap. It's below 12. Okay. So same thing here. 101 plus 15, that's 116. Subtract that from 135, that's 19.
All right. You said 135, 16 should be
Yeah,
17. I can't math today.
19.
Yeah, I was like, it should be higher than that. Yeah.
So since that's above 12, above 14, really, that's a positive anion gap.
Nice.
All right, that's the end of that one. And then we need, where was it? Cell alteration and injury. Oops, wrong thing. Why is my PowerPoint not showing? It didn't open. That's why. Oh, you know why? I opened the Word document because I had the Word document tab open instead of my PowerPoint tab because we were talking about that. Dun, dun, dun. There we go. All right. Cell alteration and injury. So cells have a couple things that they can do. Either they can resist the change, they can handle it, they can change and then come back, or they die or become pathologic. So they become altered and non-functional in the proper way. They become like cancerous. Okay, the functionality is not there. It's incorrect functionality. So types of adaptation. So here we talk about like atrophy. What causes atrophy is the shrinking of the tissue. What causes it? Disuse. So that's talking about like, and someone wears a cast for a while. So that's probably what happened here. This person wore a cast for a while. The muscle atrophies.
And how long to get like that much of a difference?
Not much. A couple days, depending on what's done. When I had my knee surgery, within 3 days, I could not lift my own leg anymore. It atrophied that quick. So when you especially if you like mess with muscle surgically, it atrophies
Mhm.
incredibly quick. Denervation. So with the spinal cord, it is sending out to maintain muscle tone at all times. So when you cut that after the spinal cord, you cut it, or if you cut the spinal cord from above the tissue or above that nerve point, everything below that is uh, lack of nervation, and we get atrophy. So you see like people that are in wheelchairs, for example, or bedridden due to nerve damage. Then we see that ischemia. If there's no blood tissue, it's gonna or no blood supply, it's gonna atrophy. Nutrient starvation. I mean, that's just anyone that's starving essentially. Uh, and there's many reasons for that, not just not eating, like cystic fibrosis, because they don't release the enzymes to break down the food. You see starvation in there. Crohn's, you can see it. And then also in like celiac disease. Right? Cell injury, so that would be like my situation when having surgery, atrophy incredibly quick. And then aging, typically due to testosterone decrease, is the causation there. Um, ubiquitin, so when we need to destroy a protein, we tag it with ubiquitin, and then a proteasome will destroy it, will recycle it, reuse the amino acids as needed. Hypertrophy. Hypertrophy. So this is enlargement of the cells. So BPH is actually benign prostatic hyperplasia. It was named hyperplasia, but it's actually hypertrophy or hypertrophy. So it occludes the urinary pathway, and so they have empty or issues emptying. Heart, you'll see it in. There's actually running a commercial now for HCM, hypertrophic cardiomyopathy. They're actually running a ad about it, if you will, about a drug or a trial that they're doing. Here, this is the left ventricle on ultrasound. This is a hypertrophic heart on ultrasound left ventricle. So the volume of blood that it can eject decreases. And so they have something like passing out, being winded. Eventually, there's not enough blood supply to circulate. They can have like a cardiac arrest or an MI, organ failure, all of that. And then these are hypertrophic tonsils.
What causes the tonsils to do that?
That could be infection. It probably is. See a little bit of white there. That's probably infection. So the person like this is probably gonna end up with a tonsillectomy because of how large they are. Hyperplasia is increased number of cells. So we have all kinds of different ones. Like this one is goblet cells, uh, endometrial tissue. So here, this is endometrial tissue that they're looking at. Right? So it's thickening. Um, uh, some hyperplasia is okay. Really, the only one is when you talk about someone going to high altitude. When you go to high altitude, because of lack of oxygen, you produce more red blood cells. It's technically a hyperplasia. There's an increased number, and it's just an increased carrying capacity. So in that situation, it's fine. Other situations, not so much. Really, the high altitude one is the appropriate one. This one up here, this is C cells, hyperplasia of C cells. You can see tons between the follicles here. We shouldn't see that much. So that's a sign of cancer. Right. Metaplasia, this is normal tissue up top. This is not appropriate. So it used to be goblet cells. It's getting abused, and so it put in stratified squamous. It switched over. This is metaplasia. This is protection. The tissue is protecting itself. So same thing with like technically like calluses on your hand could be considered metaplasia because it's stratified squamous and then it starts to technically build more tissue there. I think it is technically considered a metaplasia. It increases keratin, all that good stuff. Barrett's esophagus. So Barrett's esophagus is a form of metaplasia. Metaplasia is a sign of cancer is coming. What happens here, you have the tissue changing over. And because of this changeover, or why this changeover is happening, is the lower esophageal sphincter is failing. It's too lax. And so acid is coming from the stomach into the esophagus and irritating it. So we get this changeover of tissue. The next stop is proximal esophageal adenocarcinoma. So patients with like GERD, like I have GERD, so I take Nexium daily to prevent this. Dysplasia is atypical hyperplasia, so also associated with cancer. You're getting non-normal cells, increased numbers of them in the tissue. They do grade this depending on the type, the change. So this is like why we do pap smears. It was interesting. They actually changed. Pap smears were what, once every year?
Mm-hmm.
And now they're changing it to once every 2 years, I believe.
They said that you can only really need to have it done once every 3 years,
3 years?
but
Yeah.
insurance still pays for you to get it done every year.
Ah, yeah.
So,
My wife was telling me that because she recently went to her doctor and She was like surprised they had changed it. So he was saying they're actually causing more harm by doing a pap smear every year
Hmm.
because you're irritating the tissue. You're literally scraping it off. And so they discovered like we don't need to do it that often. It's actually increasing the risk of cancer by spreading it over every 3 years, unless the patient has an anomaly like, family history of cervical cancer, um, or breast cancer, or positive for BRCA, uh, which is a marker of cancer, or bleeding, atypical bleeding. Okay. And then so that was a sign or a reason to get a pap smear. So when they grade the tissue, so they're looking at cervical intraepithelial neoplasia. Okay, so this changeover of the endometrial surface. The biggest causation that we talk about is HPV. HPV, there are four serotypes. They only list two here, E6, E7, and I believe it's 16 and 18 that are also included in this. They cause the cells to change over, and as the tissue thickness changes, we see what's called carcinoma once we get here. So it has not broken into deeper tissue. It really hasn't passed the muscularis mucosa. Once it's passed in the submucosa, it's invasive. So that's why they're doing pap smears to try and catch it as early as possible and deal with it. Okay. All right, cell injury. So lots of reasons here for cell injury. So we'll kind of look at all of them or run through them. So oxidative stress, you talk about like reperfusion injury here. So when the patient has a blockage in a vessel, if you do not open it within a certain amount of time, these free oxide radicals are created. And so when you open it and you release it, it floods in and can actually damage the tissue. Um, we create them as well so that we can make like hydrogen peroxide, for example. That's what we're seeing here. And so these can damage tissue as well as when we release that hydrogen peroxide from our white blood cells, and it destroys the tissue. It oxidizes the tissue. That's what it's doing. It's stealing electrons from the tissue. So you see anywhere, any of these, you see, hydrogen ion or OH, hydroxyl, hydroxide, also causing damage. So there's been all these like correlations that they believe free radicals relate to. I haven't really nailed down all of them. These are, studies are still ongoing with them. Definitely macular degeneration. There is a correlation with that because it's a form of reperfusion injury potentially. And so those two are confirmed. The others, rheumatoid, yes, because white blood cells come in and they release that peroxide into the tissue and destroy it. Um, Post-streptococcal glomerulonephritis. So in that situation, we see it anywhere you see antibody and um, antigen combinations forming in the tissue in those autoimmune diseases. White blood cells will migrate, they'll release that hydrogen peroxide and damage the tissue. So in any of those, it's fair game. So hypoxic injury, this is lack of oxygen. You can't make ATP. If you can't make ATP, you can't pump. If you can't pump, things build up, fluid follows, and swelling. When it blebs, we can see damage. Okay, so that cellular swelling eventually can lyse, damage. When they undergo fermentation, pH decreases because lactic acid increases, so we can see damage. Um, just all of this is eventually damage. Eventually, the membrane is destroyed once, and nucleus is damaged. That's it. The cell is destroyed. So this is hypoxia when we look at it and we see, sodium moving in, potassium moving in because the pumps aren't functioning because there's no ATP. Water follows. There's that osmotic pressure, that pull of water. The cell swells, 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 pops. That's what we're seeing happen. Here they're showing the vacuolation. So there's these little points where there's swelling of the cells. See how there's a gap here? There's no nuclei.
Mm-hmm.
That's how you can spot it. You see how this is fatty liver. Fatty liver here, there's vacuolation. And so all these little adipocytes that end up forming in these pockets. What's the number one cause of fatty liver in the US?
Uh, Diet, probably.
Yep, exactly. Obesity here in the US, that's the number one cause. So pretty wild when you think about it. We are killing our livers here in the US not because of uh alcohol, because they always it's always kind of pushed that way. It's actually diet. Diet is the number one causation. So reperfusion injury, it's basically the same concept here. One, you can have there's no oxygen. So in itself, it's already causing hypoxic injury. And then what happens is while that fluid is sitting, we see a accumulation of free radicals, and then it comes through, and the free radicals oxidize the tissue, damage the tissue as they're passing through or entering the cells after reperfusion. So that's why it's so crucial to reperfuse as early as possible. Um, So that's one of the reasons, they say if you feel like you're having a heart attack, like chew aspirin, and chewing aspirin can help try and break up that clot and help reperfuse the tissue before there is damage and death of the tissue. Radiation, it destroys the tissue. It's as simple as that. It destroys everything in the tissue. And that's why when we damage the tissue, when you're talking about like radiation therapy for cancer, the number one risk after that, a different cancer. You've damaged those other neighboring cells. And so there is risk of mutation, risk of cancer. Chemical injury, same thing. It's just damaging the tissue directly, depending on it's toxic to the tissue, depending on what the toxicity is. Our number one detoxifier is the cytochrome system, CYP system. And so your book really just only talks about P450, but I believe I mentioned last session, there are a bunch of subtypes that they're seeing that can work on it as well. There are certain medications we take that inhibit the P450 system, such as or not medication, like foods even, grapefruit. And then there's certain medications that ramp it up. So like Nexium, a proton pump inhibitors actually ramp up the P450 system. And so you detoxify things more aggressively. Rifampin, which we give in TB, upregulates the consumption of medications. Here, they're showing liver failure, fatty necrosis of the liver. Uh, there's many reasons for this. Alcohol, Tylenol, any of those, you combine the two, um, very rapid destruction of the liver. And I have in the notes here, acetaminophen accounts for half of acute liver in the US. That's not.
Why is it bumpy on the exterior like that?
It's like the blebbing throughout it. It's just the
Okay.
destruction of the tissue and all of it like that. So what it does is it swells initially when you talk about liver failure or cirrhosis. It swells initially. We can palpate it. You can actually feel it under the ribs here, and then it shrinks and hardens as it's destroyed. And so this is shrunken and hardened, right? Um, in micro, we talk about the drug chloramphenicol.
Hmm.
Chloramphenicol is a big no-no because the consumption of glutathione which is like an antioxidant there, and it destroys the liver in like babies, and it destroys white blood cells. It's a bad drug. I know we still teach it in micro, but no one uses it. Okay. My wife was telling me she doesn't even think they have it in the hospital. They don't even order it because it's just useless, right? Chemical injuries. So on the left, lead poisoning. So this is an image of a 3-year-old. Okay, and then we see lead line deposits in the metaphyseal plates. We can see it in there. Children, young children are very common. The issue was, and I'm sure it's starting to disappear because homes are being tested for lead, but the common scenario is the young child goes over to grandma, grandpa on the weekends or whatever, and because of their height, they go up to the windowsills and they bite it. They get the paint with the lead in it and ingest it, and that's where it was coming from. That being said, so it causes like neurological disorders as well, like progression disorders. We had a scenario when I was in peds. I can't remember the exact details of it, but the child came in, and for some reason, uh, my preceptor tested the child for lead levels, and they were like through the roof. And so I think it was some family member that the child went to. Their home was very old, and so we suspected that there was lead poisoning due to that. But it was a big ordeal because you got to report it. They got to investigate. Why does the child have lead poisoning? All of that you're required to report. Okay, so yeah,
Wasn't
brain. Uh huh.
that town in Michigan was like that all of them had lead poisoning?
Flint, yeah, because it was like in the water lines, and so the lead was coming through into their drinking water. That's where it was coming. That was the big ordeal in Flint, Michigan. It's pretty wild. But yeah, it causes brain nerve damage, digestive issues because it deposits into the lining there, stunted growth. I wonder if that's why we tested the child. They were below the growth rate, something like that, and that's probably what triggered for it to be tested. Right?
So why does it build up in the epiphyseal plates?
Because that's where we're depositing calcium, and I think it binds to calcium if I remember correctly, and so as you're depositing the calcium, the lead is coming along with it as you're building that tissue.
Okay.
All right. Um, hemoglobin. Hemoglobin binds oxygen. We need it to move the oxygen around our tissue. Uh, carboxyhemoglobin. So that's the buildup of carbon monoxide. And it's binding. In my notes here, I have it's 300 times greater affinity. I remember learning 600 times greater affinity than hemoglobin. It's unreversibly bound once it binds. Um, so it shuts down the nervous system. Because it shuts down the nervous system, you start to see some interesting systems. They're all neurological in their root. So nausea, vomiting, tinnitus, weakness in muscles. And then what's the number one sign that someone has carbon monoxide poisoning?
They're sleepy.
Sleepy is one. What if they're unconscious? How do you know they potentially have carbon monoxide poisoning?
Um, they're turning blue, right?
That's what everyone thinks. Their lips turn bright red. They always call it cherry red lips. And it's due to like dilation of the vessels in there and trying to circulate oxygen through the body. But cherry red lips is a sign. And this time of year, you're going to see cases. You watch the local news and watch. Someone will do it. I remember, I think it was like last year or a family brought their grill into the house to warm the home, and they all got carbon monoxide poisoning. Heard about someone, they backed their car into the garage and every morning they would start it because it was so cold out to warm up the car. Well, the fumes were seeping into the home and the whole family developed carbon monoxide poisoning. In Florida, we hear about it all the time during the hurricanes because people put their generators in their garage and run them. So you'll hear about cases. Anything that causes combustion creates carbon monoxide. So what's interesting when you talk about that topic is it inhibits wound healing. So every time on surgery, when patients would come in for surgery, like elective surgery, we would run even just a surgery we were planning to do, not like an emergency surgery. We would look at their carboxyhemoglobin. We would test for it beforehand. And one of the questions that's on the surgical forms is, do you smoke? If you smoke cigarettes, your carboxy hemoglobin levels are elevated. Your wound healing is decreased. So when they come in with like wound dehiscence later, the wound isn't healing, it's separating, and they try and say it's surgeon's fault. It really isn't. Their body won't heal because it can't supply oxygen to the tissue. It can't create ATP because it can't create ATP. It can't do its normal function. It can't repair itself. So it was a good little sign. All right, cell accumulations. We talked about this in the last section. So as we destroy the cells or they escape the blood vessels, they're destroyed and we release hemosiderin and iron, other pigments. And so we see over time the change in color. Okay, so bruising is when the blood is starting to come out as it shifts in color, changes color to yellow. That's what we're seeing. Okay, so you can time or you can know how old a bruise is by the color. When someone comes in and shows like a yellow bruise, it's about a week old. I think it roughly is what it falls around. Whereas that bright purple, same day or next day. Yeah, yeah. Day 7 is yellow. Day 5, it's still Billy Verdin and hasn't been converted to Billy Rubin yet. So you get the greenish color. So that's 5 and 7. All right. Dystrophic calcification. So this is calcification being caused by disease, injury, or aging. So here, this is aortic stenosis. That's calcification on the aortic valves. So there's that stenosis. This is breast tissue. Typically, you see this in women after they're wearing a seatbelt and they get in a car accident, that sudden like trauma there, or they get hit in the breast tissue and they can develop it. It doesn't mean they're going to have cancer, breast cancer, or anything like that. This is probably a genetic issue where they release too much PTH or a tumor. And so they're releasing too much PTH. And so there's tons of calcium and it starts to deposit in the soft tissue. Right. You also see it with like tennis elbow. Tennis elbow, they tend to have dystrophic calcification. All right, necrosis. So with necrosis, it is a not random. It is a community destruction, if you will. One cell gets damaged. Once that cell gets damaged and it lyses, his lysosomes come out. They're released. The lysozyme's released, and it destroys the neighboring tissue. So it takes a bunch of areas out. All right. Versus apoptosis. Apoptosis is controlled cell death. The cell is broken. The cell releases lysosomes internally, destroys itself internally, and then phagocytes come and clean it up and deal with it. So they can pick the specific cell they want to destroy. Whereas necrosis takes out neighboring tissue and continues and continues and continues until it's stopped. How do we typically stop necrosis?
Cut it off.
Cut it off. But sometimes you don't have that option. That's the problem there. Sometimes certain tissues become necrotic, like pancreas or lungs or something, and you have to deal with it chemically. That's how we try and deal with it. Okay. So I have in the notes here, it's 50 billion cells undergo, right? That's billion, thousand, million, billion. Yeah, 50 billion cells a day undergo apoptosis. We're dealing with it nonstop. Okay. You have that other chart, so you can go through it. Okay. There's no need to be redundant there. So here's these other situations. So liquefactive necrosis, we're always referring to brain. There's that liquefactive necrosis. That's always referred to brain. Typically, you see this with fungal and bacterial infections. Okay. Coagulative necrosis, this is liver. We're losing sections of the liver. This is bowel. Okay. This is gangrenous necrosis. So here they've had like a volvus. Yeah, volvus is twisting of the gut. You hear about it with like dogs, with the dogs that have the high belly. They're very
Hmm.
prone to developing this, and so you'll see people. I've seen it where they say like the dog has had a special surgery where they like pin it so it doesn't do it. You see it in horses sometimes. I forget what they call it. Is it bloat? I think the like layman's term is bloat. In that situation, you have to remove the necrotic tissue, or they'll die. And then lastly, this is fatty necrosis, those little white dots. This is pancreas. So this is in pancreatitis, this is what's happening. It's just eating itself. The lipases are eating the pancreas. And so they call it saponification is another term for it. And you can see it on x-ray. Typically you see calcium deposits after that. And then this is caseous necrosis. This is lung. This is after TB. And so those types of necrosis are unique to those parts of the body. Well, what is my computer doing? There we go. It was like opening something. All right. If a stomach cell change in their characteristics and display abnormal nuclei, we call it, so the nucleus changes. It's abnormal.
Uh, it's metaplasia,
Dysplasia.
dysplasia.
Metaplasia is change of cell, but it's still functional. It's a normal cell, but doesn't really belong there. Dysplasia, it's not working right. It's weird looking. Okay. Which organelle is? Oh, this AP1 throwback. Which organelle is responsible for protein synthesis for the cell?
Um, the rough endoplasmic reticulum.
Correct, and specifically the ribosome. Oh, another one. What is found in extracellular matrix?
I mean, depending on the area, all of those.
Correct. All right. If an astrocyte in the brain secretes a chemical that acts on neighboring brain neurons, we speak of it as
Um,
his neighbor.
so paracrine,
Correct. Excellent. Excellent. Which is a product of cellular respiration?
um, carbon dioxide,
Correct. The others are reactants. And the sodium potassium pump?
um, sodium out, potassium in.
Correct. So,
So B pumps potassium into the cell. Sorry.
correct. That's it.
All right.
So, we covered inflammation. I'm not losing my mind.
Um, the next one for next week is immunity, and I think that's the only chapter kind of slated for next week.
Is it immunity or inflammation? I thought it was inflammation.
I think it's immunity.
I've got inflammation for 22nd. Chapter 6, 7?
I have everything written down. Um, yeah, you're right. It is inflammation. I don't know why I have immunity printed off, so I was like, oh, it's an I word. All I words are the same.
No worries. So yeah, next week if we meet, it'll be like ideally I want to do it where people can attend so they can ask questions. So we may try and do it like in the evening one day. Because at this point we've covered inflammation as well.
All right.
I'm pretty sure.
So review next week.
Yeah, I'm not losing my mind here. Let me just make sure. Yeah. Yeah, because after that it is immunity, and this was my last PowerPoint for this section. Yeah. Cool.
Yeah, I just printed off the other ones and was just like jumping ahead.
No problem with that. All right. Enjoy your weekend.
You too.
Email me if you
Bye.
have any questions, and I'll get this posted up as soon as it processes.
Sounds good.
See ya.
Yeah.